Good morning, folks. I hope everyone's had a great meeting. Oh, they gave me my own personal disclosure slide. You're going to see it again because I put it in myself here. So as Kristen said, I have had the opportunity with colleagues to work on the global task force on the topic of troponin testing in heart failure. So what I'd like to do is open up with a case that sort of gives the picture of why we're dealing with what we're dealing with lower and lower cut points with troponin and how they are relevant to the pathophysiology of heart failure. This is a case that came across my radar a couple of weeks ago while I was working in the hospital. It's a 74-year-old gentleman with a history of heart failure and left ventricular systolic dysfunction, known ischemic heart disease, presented with increasing dyspnea and weight gain for several days. He had no complaints of chest discomfort whatsoever. On exam, he was congested, no question about it, volume overloaded. ECG showed a wide QRS complex left bundle branch block configuration. He had a chest x-ray that showed volume overload and pulmonary edema. And his NT-proBNP, which is the natriuretic peptide we use at Mass General, was 4,875, and his troponin T was 0.05, where the upper reference limit with the 10% CV is 0.03. So this is elevated by our assay. Rechecked 4 hours later. As we do at Mass General, we recommend when there's some concern about the possibility of an elevation not due to an acute myocardial infarction, we recheck these patients more frequently, not at an 8-hour, for example, window. We'll check at 2 to 4 hours, and his recheck was at 0.04. So the question is, what does this result indicate, and how might this affect how we manage our patients? It's a real challenge, as our colleague from the cath lab brought up. So as an entree into this discussion, this table is by no means something that I want anyone to memorize, although everyone can grab their cameras and photograph it. This is just a summary of some representative trials in heart failure using a wide array of cardiac troponin assays of varying sensitivities and varying upper reference limits, illustrating the wide range of elevations that we see in patients with heart failure. So in this first study that Frank Peacock published in the New England Journal of Medicine, both troponin I and troponin T with varying degrees of sensitivity were looked at, and only about 6% were elevated. But if we isolate and just look at the range of elevations across the wide breadth of studies, we see that in some trials as many as 80% of patients have detectable and or elevated concentrations of troponin in the context of either acutely decompensated as well as chronic heart failure. And these are with the non-highly sensitive assays. So what I'd like to touch on during the next 10 minutes or so is to review the physiologic determinants of cardiac troponin, which I hope helps not just in the context of heart failure to understand what they mean, but just in the broader sense. So for, again, those concerns about, what does this test really mean and how are we to use it clinically? Some of the data that are coming out now looking at physiologic determinations of troponin are quite useful. And we'll talk also, as we just did, about the prevalence and significance of elevated troponins in heart failure, and then maybe come down to a key message or two about how we might use them. So the first point is physiologically, what do troponins in heart failure mean? And in a larger sense, what do they mean when we test in patients? So, to the unfortunate, many that work in the cath lab that deal with the fact that, we have this situation where we're more and more sensitive to what troponins are telling us. The Global Task Force section on heart failure, as a key message, wants to communicate to people that no matter how much we would like to believe that we can, as we say in Boston, blow off a result of troponin just based on the fact it's from heart failure, we want to remind people that elevation of troponin in patients with heart failure should be always interpreted, not occasionally, always interpreted with a degree of concern for the presence of acute myocardial infarction on the basis of a type 1 event. This has been again and again demonstrated to occur in up to 20% of patients presenting with acutely decompensated heart failure with a high degree of mortality if not managed in an aggressive fashion. However, the prevalent elevation of cardiac troponin in patients should also be interpreted in the context of what we know about what determines elevations in troponins in heart failure and in others. So this speaks to the discussion of what causes an elevated troponin in patients above and beyond a type 1 myocardial infarction. And there are data with highly sensitive troponin now which set the stage for a better understanding of the non-highly sensitive assays as well. These are data that James DeLamos and our colleagues at the Dallas Heart published showing, for example, And this maybe helps to understand the question about hypertension that we were just having. A dose-dependent association with left ventricular hypertrophy. So the higher the highly sensitive troponin concentration is in an ambulatory, apparently well population, the more prevalent left ventricular hypertrophy is. Even asymptomatic left ventricular systolic dysfunction. So just the presence of LV dysfunction alone is associated in a significant fashion with elevations in troponin. Left ventricular ejection fraction, another predictor, if you will, of highly sensitive troponin concentrations. The presence of ischemic heart disease, even asymptomatic, can lead to elevations in troponin in an ambulatory, apparently well population. Is this a type 2 myocardial infarction in the absence of symptoms? It's the old adage, if a tree falls in the forest and no one is there to hear it, did it make a sound? It's hard to know if we can necessarily attribute a direct, quote, myocardial infarction to the fact that patients with elevated troponins in ambulatory settings are more likely to have coronary artery disease, but the associations are compelling. These are data in symptomatic patients that we enrolled in a trial at the Massachusetts General Hospital, low to intermediate risk for acute coronary syndrome. We performed CT angiography in every subject and then examined the associations between highly sensitive troponin T and various cardiac structure and functional correlates. And I'll draw your attention to the fact that these are patients now adjudicated to not have an acute coronary syndrome, where a significant number had an elevation of highly sensitive T. And what we saw in these patients was a large percentage of them actually had previously unsuspected or asymptomatic ischemic heart disease, more heart muscle issues, including dilated LV and LA chamber size, LV mass issues, LV dysfunction, and prevalent elevations of other biomarkers of risk. So these troponins are telling us a very clear story about physiology, and it is up to us to determine mechanism using our own clinical judgment. So to summarize this piece, the physiologic determinants of elevated troponin include heart muscle disease and include ischemic heart disease, both extraordinarily common in the context of heart failure. There are other mechanisms in heart failure that have been suggested to be potentially in play with respect to the elevation of troponin in patients with the diagnosis of heart failure. There are essentially three mechanisms by which heart cells die in heart failure. It's well recognized that if you look at the hearts of patients with heart failure, there are multiple mechanisms by which the process of heart failure and remodeling progresses. There's oncosis, or cell death. There's apoptosis, or programmed cell involution, and then autophagy, where the cells essentially eat themselves and die. And at least 2 out of these 3 mechanisms lead to troponin release in experimental models. So it's important to recognize that there are multiple non-ischemic mechanisms in our patients with heart failure which likely determine the presence of and the magnitude of troponin release in this context. And many of these processes are linked very directly with the derangements that we see in heart failure, such as transmural wall stress, which increases the presence of and the severity of, for example, apoptosis. So we need to keep in mind that troponins tell us about cell death. They do not tell us necessarily about mechanism. Now, the big point here is if troponin elevation in heart failure was nothing more than a casual sort of nuisance, it's elevated but it's, quote, just heart failure, then we could sort of end the lecture here and get Fred up on the podium in a timely fashion. But it turns out actually, if you look at what it means when a troponin is elevated in heart failure above and beyond the presence of a prevalent acute coronary syndrome, it's really quite remarkable. And this may very well lead us to a new novel application of troponins heading to the future in patients with heart failure, as you'll see as I go through these data. So these are now highly sensitive troponin data, and I could show you the non-highly sensitive data. They look largely the same, but the elegance of the highly sensitive troponin data in heart failure is really quite impressive. So these data from Roberto Latini from the VALHEFT study are quite telling. In VALHEFT, over 90% of patients with ambulatory class 2 through 4 heart failure, significant advanced stage heart failure, but still not, drowning in the hospital with pulmonary edema, over 90% of these subjects had a measurable highly sensitive troponin, with a great number of them above the 99th percentile. Thus, if they were to walk into an ED with chest pain, one might invoke the diagnosis of myocardial infarction. So the vast majority were elevated, and the outcomes, that's what this slide is all about, With respect to the risk for mortality or heart failure hospitalization, were essentially linear with the concentration of troponin release in these ambulatory heart failure patients. The additive value of highly sensitive troponin above and beyond other prognostic measures, such as natriuretic peptides, was quite evident. So here in this point estimate slide, we see that if neither a natriuretic peptide or a troponin were elevated, the mortality was referent at 1. If either was elevated, there were intermediate risk. If both were elevated, the risk was higher for whatever outcome you want to look at, whether it's mortality on the left or heart failure hospitalization on the right. So this is a very real signal. In acutely decompensated heart failure, the data are largely the same. These are data that we have in press now looking at patients with acutely decompensated heart failure, essentially layering 3 different biomarkers reflecting different physiologies. Highly sensitive troponin T reflecting necrosis, NT-proBNP reflecting stretch, and soluble ST2 reflecting remodeling and fibrosis. And each was additively important for the risk of mortality in acutely decompensated heart failure. So with 1, 2, or 3 elevated, you can see the rising risk associated with their elevation. Now, while one marker is useful for stratifying risk, it turns out that as with everything in life, things can change. So when looked at serially,